But with our anxiety disorders, there are quite a few of them. And once you start breaking them apart, when we start looking at things like, say, phobias, there are many, many subtypes of each of these. But as I've said, I'm going to be highlighting the ones that are the most common. Already, we're only going to be looking at possibly 5 or 6 diagnostic categories of the 22 that are available. And within each of these, they have different disorders. So we're not highlighting all of those. But generalized anxiety disorder, panic disorder, and phobias are sort of the big ones here. Now, I've also listed obsessive compulsive disorder, or OCD, and PTSD here with our little asterisks. And that's because as part of that update between the DSM-4 and the DSM-5, these were both removed from that anxiety disorder category and are now in their own completely separate categories. It was just sort of easy enough to keep them here because they do share a bunch of symptoms, but they're actually going to be in that transition to the next topic because they share some symptoms there too. So the asterisks are meant to indicate that these aren't technically part of this category any longer. All right, so broad talk on anxiety disorders. These are going to be a class of disorders marked by feelings of excessive apprehension. Now, this is where we start making some distinctions because for a lot of the terms and concepts we're talking about, there are sort of the broad societal uses, and then there are the diagnostic uses of these terms. So apprehension or anxiety are terms that you might use in sort of day-to-day life just to talk about the fact that maybe you're nervous about something. And in that case, it's not really an extreme experience. So when we're talking anxiety disorders, we're specifically saying that it is excessive. It is far out of proportion to any potential stressor or threat that you're experiencing in the moment. So if we're looking at that, being anxious about a test, if it's not really causing big problems for you, you're just a little bit worked up. That's not going to be in the category of anxiety. That's going to be, you're nervous for a test. If you're in a fairly stressful situation, maybe you're living through a natural disaster and you're in a full-blown sort of fight or flight response that is also not out of proportion to the threat you're facing at that time, and therefore it wouldn't line up with an anxiety disorder. That's a reasonable response there. So what we're looking for is an over-the-top response to a stressor that shouldn't be eliciting that. And again, we're going with sort of standard approaches. What would a normal response be in this situation? Is this beyond that? So our frequency and intensity of these anxiety responses are going to be out of proportion to the situations that are triggering them, so above and beyond what we'd expect under typical conditions. And these out of proportion responses are going to have a whole bunch of different components. And we're going to find that these components are very similar across multiple of the disorders we'll talk about. I've kind of borrowed different ways of presenting this information from multiple textbooks over time, but this one does a good job of showing us that we have emotional and physiological and behavioral and cognitive components. Now, we find that a lot of these labels are going to line up with a bunch of our different sort of psychological approaches. So when we talked about a behaviorist approach, a more behavioral view, that's going to be those external actions, something like an operant or an instrumental response where you're acting on your environment. Physiological stuff we've talked before, so the internal biological processes, our sympathetic nervous system sort of helping ramp us up, and our parasympathetic nervous system helping us ramp down that fight or flight stress response. And both of those are sort of the balancing components of that autonomic nervous system that we got to talk about in more depth in the last chapter. Now, we also have the cognitive components, makes sense how we're thinking about it, but the emotional components are important here too, because it's how we're feeling about things. So what are some of the things we sort of lump under each of these categories? With those emotional symptoms, those feelings of tension and apprehension, that worrying feeling, that's what that's going to be describing for us. And we can have cognitive components where we're sort of maybe sort of running through different concerns that we have, the stuff that's creating that anxious, tense feeling. You can have those cognitive evaluations of that. So you might be worrying about your ability to cope. You might be worrying about stuff that's coming in the future, things that are out of your control, things that might happen. That would all fall under this. For the behavioral symptoms, we might have people start avoiding feared situations. And actually, when we start looking at a bunch of our anxiety disorders, especially into panic disorders, or not panic disorders, well, I guess those and phobias, because they go hand in hand, they often end up having a strong learned component, hence behavioral stuff having its own category. So we'll take a step back and think about this. So imagine that you've encountered a dog and you weren't really bothered by dogs. They're sort of neutral to you, but this one, say, lunges at you. They almost attack you, and you're really, really afraid about it. And then you have these internal sort of feelings. You have that fear that you're still dealing with. You have an emotional evaluation where this was awful. Cognitive symptoms. Well, now you're starting to worry constantly that there might be a dog somewhere. And then if you're worried about that, if you're concerned about dogs, maybe you start avoiding places. You have a friend who has a dog. So you decide instead of going there and feeling really awful as I'm thinking about going there where there's a potential threat, I'm going to stay home. And telling myself I get to stay home, I'm going to relax. I don't have to deal with that. I can calm myself down. And that calming down is actually a good outcome for you. And if you remember our operant conditioning setup from Skinner, if you net a good outcome, then you're going to be more likely to do that action again in the future. So I'm avoiding places I might encounter dogs, and by allowing myself to avoid it, I feel better. Now I'm more likely to avoid those situations. So you actually end up with these types of disorders almost perpetuate themselves because of these learned components. So as you engage in more and more avoidance behaviors, they are more strongly reinforced and they happen more often. You also have some sort of internalized components where the physiological can also affect your, say, startle response. This is something where, again, if you've taken learning-based classes or even 104, and you get to talk about habituation versus sensitization, for those who haven't taken those classes, habituation is when something happens consistently over and over again, and you stop reacting to it. My favorite example, I use my fire alarm example. I live in a building where they intentionally test the fire alarm twice a year, and then they unintentionally set it off another 3 or 4 times a year. So we get real used to this. But if that alarm is going off, say, every 10 minutes for 8 hours during the day, at the start of the day, if you're like me, you're going to jump. It is going to scare the crap out of you. And then by the time you're like an hour in and it's gone off over and over again, you just don't care. It's going to keep happening. I'm going to tune it out. So you've habituated to that sound. Now, if also kind of like me, I'm a nervous person. I don't do great with sudden sounds. As the day goes on, I start getting tense. I'm now worried that that alarm's going to go off again. And if it's a little bit unpredictable, maybe it's every 5 minutes, maybe it's every 15, I'm going to get jumpier and jumpier as the day goes on, to the point that even other sounds, things like maybe my phone pinging, is going to make me jump. That case, you're experiencing sensitization. So that internal sort of worked up state, so having that sympathetic nervous system as part of your fight or flight ramp up and prepare you for a potential threat, you're now overly sensitive to stuff in your environment. So that's where we get that increased startle response. It's actually started by internal physiological symptoms because your nervous system is ramped up, but it ends up being expressed or manifested in the environment in terms of your behaviors as you encounter different stimuli. And again, with that sensitization, it's not going to be specific to any one stimulus. So yeah, it was the fire alarm that got me really worked up, but if my phone goes off or if I have an alarm set on my phone, that's equally going to scare me. So interesting to find those interactions there. And then of course our physiological symptoms are going to be a standard stress response. Sympathetic system's ramped up, and therefore we're ready for our fight or flight. All right, so that's the general background. A lot of that's going to apply to all of these in some way, shape, or form, but we have a little bit of detail on generalized anxiety disorder and the other two first. So generalized anxiety disorder is, as it sounds, something where we have a more generalized or diffuse anxiety response. So this is going to be chronic high levels of non-targeted anxiety. So this would be somebody who wanders around worrying all the time. There isn't any one specific source of their worry, so it's not like our person who's developed a phobia of dogs and is constantly on alert for dogs specifically. This would be an individual who's constantly expecting maybe something to go wrong. They just have this general feeling of dread. They're worried and worked up and prepared for something to happen. So, constant feelings of dread, no specific threat that's triggering it. And because we're in this state of constantly expecting a threat, you have your autonomic nervous system ramped up in that fight or flight response pretty much long term. And we've already seen some of the side effects when we looked at chronic stress in the stress chapter. So you have things like, well, maybe you're dizzy because your blood pressure is all out of whack, your breathing's a little bit funky, your heart beating too powerfully, and your blood pressure's too high. You might be trembling because you have all of those stress hormones circulating. You might end up with muscle weakness, heart palpitations, and exhaustion because you're burning through resources that you might not have available to you. So in that case, you have sort of this constant wearing down on your system. And when we start looking at these individuals, when they've done studies on how prevalent is this feeling of anxiety, how often are you worried about stuff, these individuals spend about 60% of their day. So when we check in with them, 60% of the time, their thoughts were actively on the fact that something might be going wrong or something might be dangerous. So for these individuals, that is most of their thoughts focused on specifically how anxious and worried and tense they are. This is one that seems to be, say, fairly early developing. I will make a comment right here, which has just occurred to me. The ages in each of these, I don't care about the ages, but also they're wrong. So you'll find that when I talk about some of them sort of early adulthood versus late adulthood, this is incorrect. So ignore that part on the slide for all of these anxiety disorders. I keep making a note in my head to change them and then completely forgetting about it. But yeah, this one does start early, ignore specifically when. But the reason why we say it starts early is because this is often a precursor to other anxiety disorders. So you might be constantly in a state of alertness. And then if you've encountered that scary dog, you're now more likely to have focused on that as something that was driving those general feelings of dread. And now you're very likely to start trying to avoid that specific stimulus because you were very sensitive to it. So this tends to be a precursor to our other anxiety disorders. This one is more common in women than in men. So we do end up finding that this is one that has massive shifts depending on the culture that you're looking at. And that's again because this is one of those disorders where the symptoms are maybe not accepted in a particular group. So you might be discouraged from seeking treatment because it might be something that makes you look bad or makes your family look bad or things like that. So this one is pretty broad in terms of estimates of prevalence, where sometimes they'll say about, say, 5% of a population or about 10%, though I've seen those numbers range dramatically. So we'll just sort of leave that as vague. Sometimes we can identify a specific trigger, so maybe a really stressful event, maybe they experienced a trauma, or even something stressful that's not harmful. Having a big wedding could be something that puts a bunch of strain on you and seems to be the start of more constant worrying. But not always. So only about a third of the time can they actually track it to a single stressor. The rest of the time, it's something that seems to develop either from multiple sources or spontaneously. It completely depends. We will end up finding that all of these anxiety disorders have a genetic component, so we can trace it back to biological sources, at least as part of our predisposition, but we'll talk more about those momentarily. So phobias, we've also already introduced our example with developing a fear of dogs, but this can work in a bunch of different situations. Overall, it's going to be an intense, persistent, and irrational fear of objects or situations that pose no real threat. So again, we're in that situation of this is going to be an out of proportion fear response and constant worrying about a specific source. So unlike the generalized anxiety disorder, where it's sort of you're waiting for something to go wrong and everything makes you nervous, in this case, we have a specific source, something that's going to trigger sort of an anxious response. So for the individual scared of dogs, once you've had sort of that one encounter, you might assume that all dogs are dangerous. And in that case, you see that it's out of proportion because most dogs are not going to be problematic. If we were saying that you have a fear of bears and you live in a bear heavy area, that's probably not an irrational fear and therefore wouldn't sort of qualify here. But yeah, these are something that often are going to develop, say, fairly early on with exposure or through modeling of others. So I know that it's very common for things like fears of spiders and snakes for children to learn that from their parents. It might not develop to the point of a full blown phobia until later in life. It sometimes just starts with a general fear of them. But once we start seeing those avoidance behaviors, then it can become problematic. And that's one of those times where the environment can play a pretty large role in the development of these phobias. Because, yeah, I know that my mom is afraid of spiders, and I've watched her sort of avoid the small, non dangerous ones, but I've never really had an awful experience with spiders, so I'm kind of neutral on them. I don't really care. So, in that case, I'm not all that concerned. So, they can persist over time, they can get worse without treatment, and failed treatment can definitely make them worse. So in these cases, we want to keep in mind a lot of the components that might be contributing to these. And of course, as we figured out, this has a very large behavioral component with that behaviorist perspective. So lots of operant conditioning ideas here, just to keep it in mind. Of course, we can say our degree of impairment is going to depend on how often we encounter that condition. So that's going to be that environmental contribution. And of course, a single bad instance can be enough to set up a longer term phobia. Again, more common in women than men, though again, this might be another diagnostic bias, where in our society, it's still, while we're getting better at saying it's okay to seek treatment for things, there is still a bias where maybe men think that it's something that isn't as masculine to admit that they have this disorder. And so they might not seek treatment for it. And that's common across all of these, so I'll stop mentioning it. What are some of the other phobias? So we've talked snakes and spiders, we've talked dogs, those are pretty common, but you can also have things like acrophobia, which is our fear of heights. I'm not going to ask you about specific types of fears. You can have hydrophobia if you're afraid of water. I especially love choleraphobia, which is a fear of clowns, which I guess is common enough. They need a specific name for it. But it's always interesting to go through their lists of what things have phobias, and then especially the one that's the fear of long words, which is excessively long. I always find those interesting. But yeah, again, they're often going to be coming from a specific situation. It's actually estimated that about 10% of the North American population will have some form of a phobia during their lifetime. And about 2/3 of those can be tracked to a specific instance. Again, not always the case, but fairly common. Uh, there we go. Oh, and I did have a couple of the ones. So these are the most common in Western society. We're actually going to focus on the top two. So the specific phobias are those fears of snakes and spiders and dogs and those specific items. But you can also have more broad ones. Agoraphobia is fear of open public spaces. So this is something that can actually help, or it can explain why we see a lot of the evolution between different types of anxiety disorders, and why once you have one of these diagnoses, it is not uncommon to be diagnosed with the other types as well. Again, lots of comorbidities here, and we can usually have sort of behavioral connections between them. But if you think about it, maybe you go out in public somewhere and encounter that dog, and now you're afraid of dogs, but you've encountered dogs outside consistently. You don't have a dog of your own, so you only ever encounter dogs outside of the home. Well, now outside starts feeling awfully intimidating. So maybe you stop going outside because you know your home is safe. So in those cases, you can actually have adjustments where, yes, I avoided the outside because of dogs, but now I associate outside with dogs, so I'm afraid of outside too. So you can have sort of, it's called higher order conditioning, where you start associating things with things that you've learned to be afraid of, but it gets into a complicated process. And it's usually sort of a slow progression, and eventually people might realize that they just completely avoid leaving their homes because of those feelings of fear. We'll also see with panic disorders that this can come about not because of a specific fear of, say, dogs outside, but this could be a fear of having a panic attack out in public. So you start avoiding being out in public because you're worried about panicking, and that worry about panicking actually makes you more likely to panic. So people end up avoiding the outdoors, avoiding open spaces for that reason. So again, learned components that explain why this might pop up. And it can pop up in conjunction with other specific phobias and other disorders in general. You can also have social phobias, which is fear of certain situations, so social interactions. And this can also tie into some of our cultural specific things, where maybe there's a culture where it's really important to be respectful, maybe especially for older generations. So you might develop a social phobia where you're really worried that you're going to say something disrespectful and maybe offend someone or make your family look bad. And in those cases, you can focus and worry about that so much that it actually starts creating anxiety and other problems because of how it affects your behavior. So, as always, we can draw a lot of connections between these and explain where they might be coming from. And I've already kind of hinted ahead at our panic disorders, but these are going to be situations where we have recurrent, intense instances of anxiety, especially with sudden and unexpected onsets. So in this case, you can almost think of the other two categories as more broad, sort of heightened levels of anxiety across spans of time. But with a panic disorder, you almost get a strong burst of anxiety in a localized time frame. And this could be something that's triggered by a specific encounter, or this could be something that comes up out of the blue. And in those cases, when you have sort of spontaneous moments of panic, that can help contribute to things like that agoraphobia because you don't know when it's going to come on and you're really worried about having to deal with that in public where you don't necessarily feel safe or comfortable, or where you're violating things like social norms for behavior in public that can all become folded into it. Of course, I like to make the distinction between a panic attack and an anxiety attack because sometimes they're used interchangeably. And this is another one of those, the way that it's used in general societal use is not necessarily the way that we frame it diagnostically. But with an anxiety attack, this would be when it's usually triggered by a certain stressor. So this would be, say, you have a phobia of dogs and you've encountered a dog. So you have an acute moment of stress, you panic in the moment, it would be called an anxiety attack because we know the source. Whereas a panic attack is usually just unexpected, and we're going to have this ramping up in those anxious feelings, and oftentimes the intensity ends up spiking. So it can get to the point where you almost feel like you are immediately in dramatic danger, and that can actually trigger that flight response for our fight or flight, where you just sort of panic so much that you need to get out of there. You don't even have a specific source to point at, but you just know that you can't be where you are in the moment. So you might find somebody runs away. And again, if running away makes you feel better, you're more likely to engage in an action like that in the future. And again, that's why this can lead to that agoraphobia. Panic attacks are not explicitly tied to panic disorders alone, so they can co-occur with other disorders. So you can have, say, a generalized anxiety disorder might have spikes of panic attack. You might have it associated with some of our mood or eating disorders. Anything that's causing extreme stress might trigger something sufficiently intense to be called a panic attack. Again, we have them more common in women than men. And this one is going to develop a little bit later on in life, but again, ties a lot to some of the other anxiety disorders, so might be something that follows from those. Factors involved in our anxiety disorders, I've already been talking about the fact that pretty much all the disorders we're going to talk about are going to have a genetic component. And I always try and stress that when we're talking about these genetic components or a biological factor influencing them, we're still talking about the fact that, yes, we're going to find more similarities in diagnoses between individuals who are more closely related, but we often don't know which genes themselves might be involved. So while it's labeled as a genetic component, we're not pointing to a specific gene and saying this is what's causing it. We're still in that diathesis stress model where this is our biological predisposition, and then we have the environmental influences, which anxiety disorders do a great job of showing those environmental influences. So for all of these different disorders throughout the entire chapter, we're really talking about biological predisposition plus environment plus the interaction between the two, and we have the same kinds of patterns. So if we have both an environmental contribution and a biological contribution, we know that if we looked at, say, our adoption studies or our twin studies, or for really lucky adoption twin studies, we have some of those predictions. And we've talked about these different studies and the approaches to them multiple times throughout the course, so it should be something you're fairly comfortable with by now. But we know that if we're claiming that there is a biological component here, we're going to say that our identical twins or our monozygotic twins are going to be more similar to one another in terms of diagnoses than our dizygotic twins or our fraternal twins. And we remember it's because the identical twins came from the same fertilized egg and therefore share 100% of their genes, whereas those fraternal twins or dizygotic twins are two separately fertilized eggs and therefore only share 50% of their genes. So if genetic components matter, sharing more genes means you're more similar. And if we say there's an environmental component, then we're going to be saying that if you are raised in the same environment, you should be more similar than if you were raised separately. So if you have an environmental component, more similarities in how you're raised means more similarities in diagnostic risk. So all of that logic, none of it's new, but I'm stressing it because I may or may not have been poking at exam questions. So it's something we should definitely make note of. When we look at specific biological factors, though, we're going to find that some of our neurotransmitters can relate to some of these disorders. For anxiety disorders, they're often associated with a lot of the same neurotransmitter imbalances as depression, and that's often because the two co-occur. But we do also know that anxiety seems to relate to low levels of GABA, and GABA is just one of our neurotransmitters that is active throughout the brain. And by having low levels of GABA, we actually find that our nervous system ends up being more reactive. Basically, we're more sensitive to stimulation from the environment. So things are much more likely to trigger a response. And having this overactive sensitivity to your environment might actually explain why people would be on edge for large chunks of the time. And could then also explain why we're extra sensitive to, say, a specific stressor from that environment that could lead to learned phobias. We, of course, have cognitive factors involved. We've sort of talked about these earlier. But the maladaptive thought, this is, again, going to also be important when we get into depression. But with anxiety, you can also have constant worrying thoughts where you're thinking about what could go wrong. So you might appraise things catastrophically. So you assume that everything is going to go terribly wrong. And sometimes, especially with intense cases of anxiety, you might be looking at basically the worst case scenario for everything you encounter. So we can talk about this in terms of maladaptive thoughts and beliefs. And sometimes when we look at our cognitive therapies, which we'll do in the next chapter, a lot of that is challenging those types of thought patterns, where you might think that I'm going to be taking a test and I'm going to fail the test. I'm going to fail the class. And if we wanted a cognitive approach to maybe make people question those types of claims, we'd say, okay, well, how are you doing in the class so far? How have you done on similar tests before? And if you see, oh, actually, I've done pretty well in the class so far, and I do really well on multiple choice tests, maybe we can get people to realize that they're probably not going to fail their test. So that sort of slow question asking to get people to make their own realizations is that cognitive therapy approach. We, of course, have tons of learning factors or environmental factors, lots of that operant conditioning learning framework. So we've done that already extensively. We can also talk about things like modeling, where you are learning vicariously. You watch others engage in behaviors and use that to shape your own actions. We can also have classical conditioning, Now, classical conditioning is going to be sort of the early stages of developing a fear of something, where basically having two things co-occur means that you're likely to associate them. So when I talked about our higher order conditioning, when it came to I'm afraid of dogs and I associate the outdoors with dogs, therefore I'm afraid of the outdoors, that's technically classical conditioning. It's not until it starts affecting your behavior that we look at it in terms of an operant approach. So just as a little bit of a reminder, classical conditioning is the one we also call Pavlovian conditioning, and it's just about making links between two things that co-occur. Whereas operant conditioning is the one where we have a behavioral response based on consequences of our actions. So I avoid the outdoors because I'm afraid of it, because of its association with dogs, and my avoidance is driven by operant conditioning. Whereas linking the environment and dogs is a product of classical conditioning. Um, and then, of course, sociocultural factors. We've introduced a whole bunch of these things like what matters in the society that we're looking at, what things are people worried about, also views on what is acceptable or not acceptable to maybe seek treatment for. All of that is going to play an influence here. And I already sort of talked a little bit about why we see so many sex differences in terms of diagnoses. And it could be a sex-linked biological disposition, but it could also be something to do with the structure of society. Feeling out of control might lead you to have more worrying thoughts and therefore more anxiety associated. It could be cultural norms for expressions of emotions. This is why we don't really know for sure how big that discrepancy is between the sexes, because there are tons of other factors that might be at play. All right, and then at the end here, I said that we were going to do OCD and PTSD, but again, very crash course because they're not technically part of this category. But OCD is going to be a combination of two types of symptoms. So we're going to have obsessions, which are our cognitive components. So you're going to have repetitive, unwelcome thoughts, and usually maladaptive, unwelcome thoughts. You might even call these intrusive because they're going to pop up and sort of repeat consistently. And they become something that you focus a lot of your time and focus on. So they become sort of overwhelming. And then you have compulsions, which is the behavioral component. So if the cognitive component internally we're sort of obsessing over stuff, the compulsions are repetitive behavioral responses that we engage in because they alleviate some of those obsessive feelings. And oftentimes, this is going to be something like, I need to do this action or else something terrible is going to happen. So from sort of media displays of it, you'll see things like doing the same task 3 times over. So you lock the door, unlock the door, lock the door, unlock the door, lock the door, unlock the door, and then you can leave. In that case, the compulsion is the locking and unlocking in a set of 3, and the obsession would be the idea that I have to do this or something terrible is going to happen. And so if you don't engage in that, you might be worried that you've sort of set yourself up for something terrible. So it can often have those general anxiety ideas of you're not quite sure what's going to happen, but something awful is going to happen. And then engaging in those actions alleviates that stress, which makes us more likely to engage in those actions in the future. Operant conditioning yet again. So you can see why this was tied to anxiety disorders, but having that sort of compulsion component also means that it's more than just the anxiety. This one, unlike other anxiety disorders, is equal prevalence between the sexes. And so again, maybe there's a different biological underpinning to this because it's not just anxiety. And this is usually tied to, they call them sort of ritual behaviors because of that repetitive and sort of focused actions. And then when we look at some of the brain areas that are involved here, I think there's a couple of weird repetitions. Oh, okay, there we go. So we have a couple of different pathways that are involved here. Usually I'll go into more detail on those, but I'm actually going to skip out on those for this time because we're not going into tons of detail in general. So yeah, there are a bunch of areas involved. If you're curious, you can definitely read up on it. I'm just going to skip it because I can definitely say I don't remember making questions on that. So we'll skip over. And then, of course, PTSD, we've done the very briefest definition of this before because it shows up in things like our stress chapter. But this is going to be enduring psychological disturbance after experiencing some traumatic event or events. And I believe we talked about the fact that this could be due to a single stressor. It could be due to a accumulation of smaller stressors over time. I also mentioned that this can be not just physical stuff, but also emotional components as well, where more recent sort of revisions to this diagnosis have started including complex PTSD or CPTSD to start including the diversity of different types of triggers that can sort of precede this disorder. Yeah, this has broadened dramatically over time, but some of our symptoms here can be distress and flashbacks, depression, anxiety, insomnia, and from that you can see why it overlaps with so many other categories, and it was more beneficial to put it in its own separate category because it isn't just one of those. We do find differences in susceptibility to PTSD because, of course, you can have multiple individuals experiencing the exact same event, and some will develop PTSD and some won't. So there can be factors, say, related to personality, to life experiences. What kinds of stressors have you encountered before this? Biological predispositions might play a role as well. So all sorts of things can affect somebody's likelihood of developing it, and it's actually one of the reasons why it's so hard to predict how somebody's going to respond after a trauma. There are a whole bunch of interesting drug studies where they found that there are specific drugs that can basically separate out the emotional and the memory component so that when you have memories of an event, it doesn't pull up all the negative emotions associated with it. And it can kind of dull the memories themselves. They have to be taken within a specific window. But if somebody is likely to develop PTSD, that is something that could be delivered. But of course, they're sort of estimating, is this person likely to develop it or not? So it's kind of its own bag of worms to get into. But I know I have looked into it a couple of times because as part of somebody who teaches learning and learned processes and some of the memory stuff that goes with it, it's a very interesting application of some of that. But yeah, interfering partially with the way that we encode memories is very much an area of research for PTSD.